Okay, let me start, all right?
Yeah, go ahead, Doctor.
Okay, well, thank you for inviting me. Sorry for the problems, in fact, about the technology. I want to talk about some work that we have been doing, suggesting that the mineralocorticoid receptor may be very important in regard to the complications of COVID-19. And I think we all recognize that we need a new approach to COVID. We're obviously very dependent on vaccines, and we need to have a more effective therapy. And that's what I want to talk about today. So if we think about the mineralocorticoid receptor, Jeffrey Ariza showed a long time ago that the cloned receptor was non-selective. It bound aldosterone and cortisol with high affinity. And that was surprising. And what was then discovered, and we played quite a role in this, was that in aldosterone selective tissues, the enzyme 11-beta-hydroxysteroid dehydrogenase protects the receptor from cortisol by converting cortisol to inactive cortisone. That requires the cofactor NAD, which is then converted to NADH. And what we know is that NADH binds to a so-called C-terminal binding protein that acts as a co-repressor of DNA transcription, so that the cortisol complex, in fact, with the mineralocorticoid receptor is not then expressed. What we now know is that high levels of reactive oxygen species result in NAD deficiency and also loss of MR specificity. And just as an example of this, in the Lancet paper we published several years ago, there was a nice visual demonstration of this protective mechanism. If you take a rat and you give it labeled corticosteroid, which of course is the equivalent of giving cortisol in man, and we then do, an hour later, we take the kidney out, do an autoradiograph, we find no uptake, in fact, in that kidney. But if we then give an inhibitor of that enzyme so that we block the conversion of cortisol to cortisone, and then do the same experiment, we get a remarkable difference. We suddenly find that we've now got an extraordinary uptake, in fact, in the kidney. This is now where the unprotected mineralocorticoid receptors are now taking up the label cortisol, or corticosteroid in this case. And so what I'm wanting to suggest to you is that what the virus does is, in the tissues that it infects, it actually does exactly this. It loses the specificity of the mineralocorticoid receptor, and that has very particular consequences. A few years ago, we did an interesting study which we published in PNAS. This is the Gorlick paper in 2005, where what we were doing was adding aldosterone to renal epithelial cells and then using a very clever technology, which Yuri Kurchev is the world expert, that's a chap in our lab, and this is so-called scanning ion conductance microscopy, where you can scan these cells, living cells, and see what happens. And if we look at 1, 2, 3 here, these are flat cells here. We add aldosterone, and we suddenly find over the next few minutes that they, in fact, change shape, and the surface, in fact, becomes very rounded. And what we found was that when you've got a flat cell, if you patch clamp this flat cell, you find there's no sodium channel activity. Where it's changed shape, then you get sodium channel activity, it's opened the sodium channel. And so what we realized was that there was something rather remarkable happening. We went on to demonstrate that when you stimulate the cell, that you then release ATP from the cell. The ATP acts back, in fact, on purinergic receptors on that cell, you get calcium entry, and that results in contraction of the cell and opening the sodium channel. And then that obviously gave us a different perspective. Now, let me come now to the question of what happens with the infection with a virus, the coronavirus. We all know that the coronavirus uses the ACE2 receptor to get into the cell. In the process, it destroys the receptor, and you end up by having cells which are unable then to convert angiotensin 2 to angiotensin 1 to 7. That results in high levels of angiotensin 2 stimulating NADPH oxidase. The NADPH oxidase results in reactive oxygen species, high levels, and they would normally be inhibited by angiotensin 1 to 7 acting by the MAS receptor, but that's not available. So you get these high ROS levels within the cell. So the key hypothesis that we've been looking at is that after the entry, it gets into specific cells. And I want to focus to start off with, in fact, on epithelial cells. And these are in the nasoepithelial cells, so-called sustentacular cells lining Bowman's glands, in keratinocytes, type 2 alveolar cells. What is fascinating is that these all have mineralocorticoid receptors and 11-beta-HSD2. And when the virus infects these cells, the loss of the receptor results in these high levels of ROS. The end result is that the MR is no longer specific, and it's now stimulated, in fact, actually by cortisol. And this then leads to release of ATP. And what I'm then suggesting is that that locally released ATP is then responsible for these key symptoms, and those are anosmia, ageusia, and cough that you get, in fact, in patients with this infection. So if you follow your nose, it's really quite interesting, because if we look at a nose, we have here a number of different cell types. Here we have the olfactory receptor cells, the green here, and the nerves coming out, in fact, actually here into the nose. Here we have the yellow are the so-called supporting cells, and here we have the cells lining Bowman's gland, the mucus-producing cells. And what we know is that the cells that have the ACE2 receptor are these cells lining Bowman's gland, and the cell, in fact, the supporting cell, but not, in fact, the olfactory receptor cell. So the question is, how does the infection then end up, in fact, by producing the loss of smell? Well, we know that historically, a lot of viral infections in the nose actually destroyed cells and ended up with long-term anosmia. But that isn't the case, in fact, here. The anosmia is much more short-term that you get, in fact, actually following COVID infection. And so if we look at this, the anosmia and the ageusia, we know that purinergic receptors are absolutely key in taste and smell. And what I suggested is that you get this exocytosis of ATP acting on olfactory nerves. And Hager and colleagues showed very nicely that exogenous and endogenous ATP very significantly reduced odor responsiveness, and this was worked via P2X and P2Y receptors. They showed that it was, in fact, a nociceptive response. It was a protective response. And the same thing is happening in the tongue keratinocytes, but not in the taste buds. Taste buds are embedded in these cells, and the keratinocytes are known to release ATP. And so I think exactly the same mechanism is happening, in fact, within them, leading to your loss of taste and smell. And then if one goes down into the lung, and we go to the so-called type 2 alveolar cell, this cell, which is the cell which has the ACE2 receptor, is the one which is first infected by COVID. That what happens is exactly the same thing. It has a mineralocorticoid receptor, it has 11-beta-HSD2. You then lose the specificity of that receptor, it's activated by cortisol, you release ATP. The ATP then acts, in fact, on purinergic nerves, on what are called neuroepithelial bodies, which in fact are around the alveolus. And these are then very highly innervated with purinergic nerves. And this then leads to activation, in fact, of the vagus nerve and your cough. So that's the non-productive cough that you get, in fact, clearly as a characteristic feature in this condition. We also know that extracellular ATP is a danger signal. It triggers macrophage, and we've heard a little bit before about the NLRP3 inflammasome, and this is via the P2X7 receptor. And in order to activate the inflammasome, you need a priming signal and, in fact, a second signal. And the priming signal can be ROS, and the second signal can be extracellular ATP. And obviously, in this circumstances, you've got both. And so you're then, in fact, actually producing your inflammatory response. So those are sort of the key initial things that I think happen. If we now move to endothelial cells, what's been shown is that normal endothelial cells have extremely low levels of ACE2 and are very, very difficult to infect with the virus. Very nice work from Imperial showed that. And it was then strange because we now know that this condition is very much an endothelitis in its complicated form. And so how does the virus then affect the endothelium? Well, Kaneko now produced a very nice paper in which they showed that the ACE2 levels are, in fact, indeed very low in cultured monolayers, which people have been looking at. But when they then produced a 3D model where expression of the ACE2 was then looked at, they could show that the ACE2 expression was markedly increased in relationship to flow and vessel size. And they then went on to produce a model where they had an intracranial artery stenosis model and showed that ACE2 expression was high in the stenotic part and the post-stenotic portion. So what it's suggesting is that patients, as we know, with vascular disease, with hypertension, etc., and are much more prone to developing, in fact, this COVID complication, that you then increase your expression, in fact, actually within those particular cells that are affected by it. We then went on to suggest that it is particular contents within the endothelial cell that are then vital for the complications of COVID. And this nice picture that Tom McKinnon and Anna Randy kindly let me use is of these so-called viable Pollardi bodies, in fact, within endothelial cells. And we know that when you cut yourself, you release these bodies, and they're key in stopping you, in fact, from bleeding, etc. And so if we start looking at what's in them, the main cargo of the viable Pollardi body, in fact, is the von Willebrand factor. And what we know is that these viable Pollardi bodies are released by exocytosis from endothelial cells. And when they come out, they produce these extraordinary multiples that are strings, in fact, on the apical side of the cell. It produces an amazing spider's web, then acts as a platform for platelet adhesion and the formation of microthrombi. We know that microthrombi are dramatically more common in the lungs of patients with COVID as compared to influenza at postmortem. And we know that patients with this complication of COVID have very high levels of von Willebrand factor. And so that's an important sort of thing for us to then consider. But there are other things contained within the viable Pollardi bodies, in particular, this molecule, angiopoietin-2. And this is normally found in atheroma chromocytes in a very high concentration within the viable Pollardi bodies there. And normally we have, in fact, angiopoietin-1, so particularly produced, for example, in the lung, that protects from plasma leakage. But angiopoietin-2, if it's released, actually blocks the receptor that angiopoietin-1 normally uses, and that then results, in fact, in inflammation and a dramatic increase in permeability. And there are very nice experiments showing this extraordinary effect where you get leakage in the lung. And so not surprisingly, it's been found that plasma levels of angiopoietin-2 are proportional to the acute respiratory distress syndrome severity and are strongly predictive of poor outcome in that condition. A nice paper was produced, in fact, by Jiong et al. And published in PNS, in fact, that they then went on to show that the mechanism that we had described of aldosterone activating the release of ATP, when you looked at this in endothelial cells, produced exocytosis. And so they looked at the measurement of von Willebrand factor and showed that when they added aldosterone, that there was then a progressive increase in release of the von Willebrand factor as it was with thrombin. And this is important because it's just exactly the timescale one would expect. This is an ATP dependent phenomenon, as we've described before. And so what they then did was to show that this could be, in fact, blocked. So even though it's an early effect of the release, it can be blocked by blocking the mineralocorticoid receptor. So spironolactone, so here we are stimulating von Willebrand factor release with aldosterone, and here we are increasing doses of spironolactone blocking the release of the von Willebrand factor. And so obviously that raises the question as to whether this is relevant in the pathogenesis and possible treatment, in fact, of patients. And so what we decided to do was to test this hypothesis that the inhibition of the mineralocorticoid receptor would block the release of ATP and hence would reduce symptoms in terms of cough, restore the sense of taste and smell, and also the reduction of the release of the inflammasome would lower inflammatory cytokines and inflammatory markers, such as C-reactive protein. We also obviously were very, very anxious to look at the question as to whether it would inhibit the exocytosis of viable Pollardi bodies and hence lower the circulating levels of these rather lethal compounds, reducing microthrombi and ARDS. And so there have been two proof of concept studies of this. One was published, in fact, by Vicenzis et al. In Journal of Clinical Medicine, and the other is one that we have yet to publish with these results, which we've recently had. Now, the study by Mackenzie was done in Milan. They had 69 consecutive patients admitted to hospital with moderate to severe respiratory failure and COVID. Group A had standard therapy, which included methylprednisolone, and Group B were given canrenone intravenously. Now, canrenone is a major metabolite of spironolactone. And the study that we did, which has been done by Dr. Klikot and Dr. Larisa, who are in the Vinnytsia National Hospital in Ukraine. Dr. Larisa, in fact, is the head of infection there, and Dr. Klikot, in fact, is an assistant professor there. And then Professor Yuri Kochev and I are at Imperial College. And what was done was to look at 80 patients admitted to them in Ukraine with hospital with COVID-19 and radiologically confirmed pneumonia. And Group 1 were given standard therapy, including high-dose dexamethasone, what is currently being done, and came very much from the recovery study. And they also, of course, had antibiotics. And then Group 2, we gave low-dose dexamethasone, spironolactone, and an antibiotic to. So if we look now at the studies, well, this is the Milan study. They had 39 in their standard treatment, 30 given canrenone, and they had a fairly typical male-female ratio, far more males than females. And it's known, of course, that this is very much what we've seen in most intensive care units around the world. Their average age was 60. If we then look at the outcome, it was fairly remarkable in that they had a death rate of 36% in those on standard treatment, 13% of those given canrenone, and 49% of those on standard treatment required ventilation. Only 20%, in fact, actually, of those given canrenone. So clearly there seemed to be a very interesting preliminary evidence suggesting that blockade of the mineralocorticoid receptor was likely to be of benefit. In the study that we've done in Ukraine, it's a little unusual because we've found that men in Ukraine are apparently extremely reluctant to go into hospital. So we had quite a lot more women to men. And so we had these two groups. One was what we call the high dex group, which is given 60 milligrams per day of dexamethasone. And the other is the low dex group, which is 4 milligrams per day plus 100 milligrams per day of spironolactone. This was given for 10 days. We had one death, in fact, in the conventional high dex group, no deaths, in fact, actually in the group given the spironolactone and dexamethasone. I'm afraid that this slide hasn't come out, but in fact, what it shows is that actually that the symptoms that we had in terms of the loss of smell and taste, the sore throats, all the other classic symptoms, cough, fever, etc., were very similar, in fact, actually in the two groups. I'm sorry that hasn't come out. And then if we look at the comorbidities, there were some classic comorbidities in the two groups of hypertension, ischemic heart disease, diabetes, in fact, actually 25%, obesity, 40%, 48% in the two groups. So classically, what you would expect. And if we then look at the results, in fact, that we had, we found this is looking here at the high dexamethasone, this is looking at spironolactone dexamethasone. When we are then looking at, this is blue line here, which is the baseline. So this is the number, percentage of patients, in fact, actually, that had blood oxygen less than 92, and then this is post-treatment. And similarly for fever, cough, dyspnea, sore throat, etc. Down here, the spironolactone and low-dose dexamethasone. And on every single measure, the result with the spironolactone and low-dose dexamethasone actually were better than with the high-dose dexamethasone. If you look, say, for example, take loss of smell and taste, after 5 days, there was a very small reduction in the high-dose dexamethasone. It was nearly halved, in fact, in those on spironolactone dexamethasone. And all the other things, features here, sore throat, etc., were lower than with the conventional treatment. If we then look at the biochemistry, the C-reactive protein inflammatory marker was significantly reduced in high-dose dexamethasone, but it was further reduced, and these results are significantly different between the high-dose dexamethasone and the spironolactone and dexamethasone. Similarly, if we measure D-dimer, a critically important measure, in fact, of your clotting problems, this was reduced significantly in the high-dose dexamethasone, but again, it was further reduced, in fact, in spironolactone, and the spironolactone group was significantly lower than the high-dose dexamethasone. Not surprisingly, the blood glucose was higher in high-dose dexamethasone significantly than it was in the lower dose of dexamethasone. If we then look at the dynamics as far as the radiology is concerned, all 40 patients, as I said, had pneumonia evidence on the X-ray before treatment. And if we then look at what happened, that following treatment, in fact, with the conventional treatment, then we found that 15 of these patients, in fact, were improved. There was resolution, in fact, of the pneumonia. But in 5 patients with conventional treatment, they then relapsed. In fact, it deteriorated, in fact, at 5 days. It was worse. And so that was that. Then looking at the treatment with spironolactone and low-dose dexamethasone, 24 of these patients, there was resorption, and no patient, in fact, actually was worse. So there was a difference between those. So that was then obviously a time for us to then summarize for what we found. So what I've done is to suggest that following infection of the cells with the virus via the receptor, that there's a loss of specificity of the mineralocorticoid receptor, and then they're now activated by local cortisol. Activation of that results in the release of ATP, and then epithelial cells that stimulates local purinergic receptors to produce these classic symptoms of cough, anosmia, loss of taste and smell. And that also there is local cytokine production. And then in endothelial cells, when these are infected, when they express the ACE2 receptor, the activation via ATP produces exocytosis of viable pollarded bodies. These contain the von Willebrand factor and angiopoietin 2 with consequent microclotting and ARDS. That's yet to be absolutely proved because we haven't got these measurements yet. In our 2 proof of concept studies, we think that we have got evidence that blockade of the mineralocorticoid receptor produces major benefit. In the Milan patients, this was, I think, fairly remarkable. The mortality, in fact, was 13% versus 36%. And they, in fact, actually were obviously very much better from the point of view of the low percentage that are required to go into ventilation. In the Ukraine patients, where we had clearly a milder group, what we found was that there was a more rapid amelioration of the symptoms, the cough, the fever, anosmia, agusia, shortness of breath, and the signs, and the biochemistry, and the radiology as compared to high-dose dexamethasone. In Milan, what they did was to use quite a high dose of canonane, 200 milligrams per day, which is equivalent to 140 milligrams of spironolactone, and it's, of course, given intravenously. What we used in the Ukraine study was to give this lower dose of dexamethasone, 4 milligrams a day, and what we were aiming to do was not to use it as an anti-inflammatory drug, which is what people are constantly saying they're using it for, but to suppress cortisol secretion so it doesn't activate the mineralocorticoid receptor. And at the same time, we give spironolactone 100 milligrams per day to block that. Obviously, we now need to have larger studies, and we've got these larger randomized studies of dexamethasone and spironolactone, which are now underway in Delhi, Moscow, and in Chita. And obviously, when we've got those results, hopefully, if they confirm what we've been seeing, we may be in a better position to treat patients, in fact, actually, who've got this, I think, pretty disastrous condition. The world has been brought to a full stop. And if we can make the disease a much less lethal disease, then perhaps we can do something which is terribly important. So thank you very much for listening to me. Thank you.